All right, guys. So this is part two of essentially surviving sim lab, putting your care plans together, where I'm going over my 3-step process to thinking about and approaching your care plans. And even you can use this when you're starting clinical because it can be so overwhelming. So this is part two. In part one, I talked about gathering information about your patient, essentially your pre-op review, your pre-op assessment. That's step one. The second thing is looking at all the surgical factors. What is the surgery? Who is the surgeon? How long is it going to take? What is the positioning of that? And all the things that go along with that. And then once we have those two elements in place, right? We know our patient, we know our surgery. Now we get to go to our toolbox and choose a plan that works for this surgeon, this surgery, and this patient, right? And I want to start off by saying sometimes there is no perfect answer. There is the answer that there's the plan that you choose that is the best risk versus benefit. You're constantly risk versus benefit, because different patients, different surgeons, different surgeries will have different challenges, right? So there is no perfect answer in anesthesia. There is no protocols. I know we're always looking for, I just want like a protocol to go through. Those do not exist in anesthesia. It's just you thinking, troubleshooting, thinking critically, all the things. Okay. So what do you have to choose from now that you've got all your information together? You have, these are your two, basically your general anesthesia options. So general endotracheal tube anesthesia, or GETA. So you're using an endotracheal tube, you're intubating them, you're putting them all the way to sleep, you're paralyzing them because you're tubing them, right? General anesthesia with an LMA, a laryngeal mask airway. Love that. I love LMAs. I use them all the time. You really don't have to paralyze with an LMA. They're great. They're like essentially like a fancy little airway you can use that you can give gas through. MAC, which is monitored anesthesia care, which for the purposes of this video, it is essentially anesthesia or sedation given by an anesthesia provider, which means basically just means that we can kind of flex how light or deep we go. Okay. Sometimes we even will say this like, well, a surgeon will be like, you can do a MAC, but like make it a deep MAC. And sometimes our sedation kind of goes into the realm of general anesthesia, but you will learn all those little nuances as you go. Okay. But just know you can give sedation. And then we have a regional anesthesia, nerve blocks, spinals, epidurals. Okay. So these are all the things that you have in your toolbox. Okay. So now knowing what I know about my patient, knowing what I know about the surgery, what is going to be the best and safest anesthetic for this patient, right? And keep in mind, sometimes anesthesia is surgeon specific. One place will do something MAC, like sedation, and then another place it'll be a full-on general, right? It just depends on your CRNA, your doc, your MDA, your anesthesia providers, their comfort level, the surgeon, the facilities, their culture, all the things. Okay. So you will just have to learn to be flexible. If you are nothing else in this job, you will be humbled and you will have to learn to be flexible. Okay. Okay. So essentially general anesthesia, rendering the patient completely unconscious. You are taking over their autonomic nervous system. You are putting their airway reflexes to sleep. You can use an LMA, you can use a tube. And like I said earlier, because you want to protect the airway, if you're going to put their brain that deeply to sleep under general, we have to protect their airway. Okay. LMAs, you can put those in. Like I was saying, I usually use a combo of like Versed, fentanyl, lidocaine, and propofol. Okay. You do not need a paralytic to put an LMA in. ET tube, you generally are going to use succinylcholine or rocuronium or VEC or something to paralyze them, depending on length time of the surgery as well. Of course, there's exceptions to all of these things. If you put an LMA in, maybe you need to paralyze them. That's kind of a little controversial, but like I said, there are no just perfect, correct, all the way right answers all the time. Okay. And then obviously ENT, pediatrics, stuff like that, special populations, different, a whole different ball game. But for the most part, this is the general anesthesia thing that you have. Cases that might require endotracheal tube intubation. Prone cases, some pros are done MAC, but prone cases, usually spine cases, are going to be, general anesthesia, GETA. Shoulders, let me see. I'm trying to think of some other things. Robotic cases are usually going to be, I'm trying to think, there's always usually going to tube. Robotic cases, laparoscopic cases, nephrectomies, hysterectomies, hemicolectomies, all those things like that. You're going to be most likely tubing them. Now, LMAs. I will use an LMA for just about anyone, anytime, anywhere, any place. I freaking love them. So you're usually thinking of cases that necessarily do not need full-on paralysis, like the one I just mentioned, laparoscopic, robotic, stuff like that. Um, hysteroscopies, podiatry, urology, some plastics, hand cases. Those things can also be done with sedation, MAC as well. You can even do blocks. If you have like an orthopedic case, you can do like a nerve block, and then you can do MAC anesthesia or even pop in an LMA. Just kind of depends, right? But I'm the LMA queen and MAC. Like I will do MAC on just about anything as well, if the surgeon is good with local anesthesia. All right. So if the surgeon's good with local, you can MAC just about anything. Okay. Besides, like I said, robotics, laparoscopic, no, those need to be tubed, paralyzed, all the good stuff. Now MAC anesthesia is a skill set, okay? You can pop an LMA, a tube in somebody, flip on the vent, turn on the gas, you can be rocking and rolling. Now MAC is going to be your superpower, right? It is harder than an LMA, harder than an ET tube, because you have to keep this patient asleep, not moving, and still breathing. Okay, that's why I'm saying the surgeon has to meet us halfway and be good with local as well. But I have done MAC. I work with a plastics guy, and he basically does all his facial plastic stuff, everything MAC. Okay. So it just depends. For other people, I tube everybody. Okay. It just kind of depends. But if you can learn while in school how to give a really good MAC anesthetic, mwah, chef's kiss. Okay. And a lot of this, especially with MAC too, is a lot of it's knowing your drugs. I will link my drug drawer guide below that goes through all of our, medications we use, knowing them in and out, etc. But this is why it's so important to know your drugs. Okay, kind of it fits in your anesthesia toolbox, fits in all your drugs go here. But that would be like I could talk about drugs all day long. Okay. Regional anesthesia. Like I said before, a lot of ortho cases, you can think about doing blocks. Like I said, culture depends, surgeon depends. You can do blocks pre-op, like interscaling blocks for shoulders. Sometimes surgeons like to do a neuro check afterwards. So you can do the blocks post-op, and then you would still either choose like MAC with regional or sometimes ET tube or LMA. C-sections are going to be spinals for the most part, unless you have an epidural in and they've had to be transitioned to a C-section. You can use the epidural. You can also use like any belly cases, like hemicolectomies and stuff, or even prostates. You can do a single shot spinal with like some morphine in there. And sometimes, like I said, with hemicolectomies, you can even put an epidural in and dose that. Thoracic cases, put a thoracic epidural in and you can dose that, but your patient is still intubated and asleep on the table. So you're doing regional and general anesthesia, right? And how we bill or how we document is what is like the main anesthetic. For C-section, it's going to be spinal. We usually do tap blocks for those. You're doing a spinal and then you're doing like a regional afterwards. But the main anesthetic you're using, that's how you bill. That's kind of what you focus on. Once again, that's getting in the weeds, but I just want to throw it out there so you guys have that kind of knowledge there, right? Essentially, there's a lot of variety. You can get creative. This is why you're going to go into clinical and you're going to pick everyone's brains. You're going to learn all the things and you're going to do all the things because there's so many ways that you can do something. And this is why communication is key, communicating with your patient, right? About what to expect with the anesthesia. If they're super sick and they have no EF, usually try to do sedation. I usually tell them, I might have to wake you up a little bit. If you are unstable at any point, you might hear me saying your voice, hearing my voice saying everything's okay. Like you have to set your patients up for success as well. All right. Talking with the surgeon. What do you think is best? This is what I'm thinking. This is what I'm worried about. What do you need? Right. This is the job. Looking at your patient, knowing your surgeon, knowing the surgery, looking at the position, right? And then choosing the best plan that you can, and then having backup plans for those backup plans. All right. And then executing it, tweaking it, learning from it, and repeating. This is truly the job. If you guys have questions, please drop them below. And like I said, I will also link my drug drawer guide below if you want to check that out as well, because that's a whole other talk. But this is your 3-step process to how to start thinking about putting your care plans together. So happy anesthesia, guys. I am so excited for each of you. And like I said, drop questions below. I'm happy to do more videos if this was helpful, or if you want me to go in depth on certain things. Because like I said, this could be some heavy topics, but I just want to give you guys an overview so you can get to work on creating those care plans, having a little bit of fun, and being competent, awesome CRNAs. All right, I'll see you guys later.